And then I see a question on how to now summarize and phrase this examination. Right, so the way I will write this is that number one, stage 2 or stage 2.5 Parkinsonism, likely idiopathic Parkinson's disease with akinetic rigid presentation, right? So we're not seeing a resting tremor. And so it looks akinetic rigid. There is not much of a resting tremor, and but it's likely idiopathic Parkinson's disease. Although we don't have the history, we don't have full examination, but I'm not seeing any huge red flags here that tells me this is not idiopathic PD. So stage 2 Parkinsonism, akinetic rigid, likely idiopathic PD. That's number one assessment. Number two, I will say multifocal dystonia, including facial dystonia, neck dystonia, and right foot dystonia, left arm and right foot dystonia, and possibly jaw dystonia. Number three, dystonic tremors in left arm, maybe in the left leg. And number four, I would say will be, so these are the things on examination, three things that we've seen so far. Number four would be postural instability if her pull test was 2. Number 5 will be any REM behavior or hyposmia that she has. Number 6 will be if she has any dysautonomia or something like that. So I will list them, and then I will start with a summary. So I'll say, let's say 63-year-old right-hand female with no family history of Parkinson's disease is presenting with an onset in 2016, gradual progression, responses to levodopa, is now taking this much, and has REM behavior and hyposmia as Lewy body markers suggesting Parkinson's, so on and so forth. So I will summarize the history part in medication, and then I'll go to examination. Her examination showed typical Parkinsonism with bradykinesia, which is bilateral, worse on the left side compared to the right, along with rigidity. She has no resting tremor identified. She has some postural reemergence tremor that seems mostly dystonic, associated with dystonic posturing, seems jerky, irregular. And then she has facial hypomimia with jaw opening, maybe jaw dystonia, maybe there is a jaw dystonia. And then I go on to multifocal dystonia that I observed that her grasp was this way. We had dystonic posturing. She had dystonic tremor. She had right foot dystonic posturing. She had a cervical dystonia with prominent neck muscles, with posturing or something like that. So I describe the multifocal dystonia, and then I will say, okay, red flags. The red flags, if any identified, are these that we have not done in this exam so far. And then I will write why I think it is still idiopathic PD, even if the red flags are not red flags, or although this is akinetic rigid. So I can say that, other differential like MSA and PSP cannot be fully ruled out, but the patient has been progressing slowly. This multifocal dystonia seems to be levodopa responsive, or it's not in an unusual pattern, and she has slight asymmetry between the two sides, and so on and so forth. And that's why I still think that this is idiopathic PD and not something else, but differential will include this and this. And then I will go on and say that we discussed treatment options with the patient, and the treatment options included increasing levodopa or adding an adjunct MAO-B inhibitor or this and that. And then I will talk a little bit about what is the pros and cons of one treatment over the other. And then I will mention if I discuss the PBS treatment or duopa treatment with the patient. And then once I've done all these descriptive discussion, then I go to the plan section, and then I write clear, pertinent, prudent plan that these are the action items. So number one, I will continue her cinema at 25, 100 milligram, 2 tablets 4 times a day. Number two, we'll start selegiline 5 milligram twice a day. Number three, I will refer her to physical therapy for balance training and gait training and balance evaluation. Number four, for her REM behaviors, I will encourage her to take over-the-counter melatonin, and then call me back in 1 month if the REM behaviors have persisted or gotten worse. And then so on and so forth. So if there are other action items, I will list them one by one that I'll do this, I'll do this, I'll do this, she'll call me back, I will call that person, I will make a referral, and I will see her back in 3 months or 4 months or 6 months, whatever. So that plan part is my action item list that I can quickly go to next visit, or if there's a phone call and I can tell what was my plans, what was I going to do. And then assessment is where I discuss everything, any plan, any workup. If I say that I need to do that scan, if I say I need to do autonomic reflex screen, why I need to do it, what am I thinking, and then I write down what I think the result will be, and that's called the pretest probability. So I'll say I'm going to plan to do a DET scan, and I think it will be abnormal, and that's the pretest probability of the DET scan that is necessary to estimate the reliability of the answer. So if you say it is going to be abnormal and it is abnormal, it's far more reliable than if you say if you say it's going to be abnormal but it is normal, then it's less reliable, and then you have to, the reliability goes down because pretest probability was low, that it's going to be normal. So then that reflects in calculations on positive predictive value and negative predictive value of a test.